Here we describe the senior author's technique for the outside-in percutaneous release of the medial collateral ligament during knee arthroscopy for patients with a tight medial compartment of the knee in which valgus stress alone is insufficient in adequately revealing the intra-articular anatomy or to allow for instrumentation to occur without causing iatrogenic cartilage damage. The author's disclosures are listed here.
After setup and positioning for knee arthroscopy occurs, an arthroscope is used to visually inspect the intra-articular anatomy in a standard manner for a diagnostic knee arthroscopy. During inspection of the medial compartment of the knee, which is pictured, a valgus force is applied to the leg by the surgeon or an assistant in order to increase the medial joint space. As in this case, if it is determined that medial access is restricted in allowing adequate visualization of pathology or safely facilitating instrumentation without causing cartilage damage, a percutaneous release of the MCL may then be performed. An understanding of the anatomy of the medial knee is relevant to performing this percutaneous release. As described in the diagrams provided by Laprade and Associates, the superficial MCL's femoral attachment is on average 3.2 millimeters proximal and 4.8 millimeters posterior to the medial epicondyle.
In the technique we describe, bony landmarks are found by palpation, and the medial epicondyle and tibial plateau are marked with a skin marker. With knowledge of the described anatomy of the superficial MCL by Laprade and Associates, a mark is made in the posterior aspect of the MCL just proximal to the joint line. This point is measured out 1.5 centimeters posterior and slightly distal to the medial epicondyle.
While a constant valgus force is applied to the knee by the surgeon or an assistant, an 18-gauge spinal needle is used to penetrate the skin in one location. Subcutaneously, the spinal needle is translated in an anterior to posterior direction as fenestration of the MCL is performed. We prefer to release the superficial MCL just distal to its femoral attachment. Simultaneous visualization of the medial compartment should occur while the percutaneous release is being performed. Typically, an audible pop is heard that corresponds with an acute increase in medial compartment joint space. As demonstrated in this video, the acute increase in joint space from the performance of the MCL release reveals a meniscal tear that was previously unable to be identified. Finally, two static side-by-side images demonstrate the improvement in visualization following the performance of the percutaneous MCL release.